I think there are several factors. The first factor is perhaps related to nutrition and the lifestyle change during the COVID. We see a specifically larger increase in the year 2021. We think that might because during the COVID, people mostly have quarantine, staying at home. So maybe the increase is related to this lifestyle change. And also because of this change in health services, um, we suspect it might because of the claims. So people are more likely to use health service research before the pandemic. And during the pandemic, there's a continuous enrollment regulation that more individuals are enrolled. So it might be these individuals, they do not have health insurance before the pandemic, and now they gain insurance, so they are more likely to use health services. That may also lead to a increased rate of diabetes.
So, another follow-up to why we might have seen this increase in pediatric diabetes, apart from the two facts Dr. Zhang mentioned, which is lifestyle changes and the fact that a lot more people were staying enrolled because of continuous enrollment. There is also speculation, not quite confirmed yet, I believe, about whether exposure to the COVID virus in itself was a risk factor for making children and youth more susceptible to getting diabetes. So, sort of to be clear, what we really saw was the groups that had historically been considered lower risk, pretty much catching up, they were showing faster rates of increase than the groups that had historically been perceived as high risk. So I think maybe there was a degree of assumption around diabetes as mostly a problem in the southern states of the US, or it's more of a problem among female youth. And I think mostly what our data shows is don't be complacent because it is increasing faster among groups previously considered to be not so high risk. So screening protocols and guidance of who's at risk, etc., need to adjust given that information.
We found urban youths have a relatively lower baseline prevalence of diabetes, but it's increasing faster compared to rural youth. I think one explanation is that rural youth, they may have less accessibility to healthy food or good quality physical exercise, like playground or parks. So that may contribute to their higher prevalence. But we see a faster increasing trend among urban youths. I think this, as we mentioned previously, maybe because like in COVID-19, everybody stay at home, they do not have physical activity, and also they have like maybe experience mental psychological stress that is have a heavier impact on the urban youths, but we are not sure about that. So what we see is they are increasing faster compared to rural youths.
And as a follow-up, I will also speculate, again, this is pure speculation, that if people were more apt to get screened because through continuous enrollment they now had Medicaid coverage, the ability to access the screening and access like a primary care doctor's office is probably higher among urban youth than it is among rural youth. So it's likely that urban youth were just getting detected more because again, everything you're seeing in our data is only if they actually visit the doctor and get detected. So I have to say that is a huge part of our team's entire research agenda, this understanding what is driving delayed diagnosis, lack of timely diagnosis, lack of screening, and so forth. And for example, in a related project which we've presented, not yet published, we found that a fairly high number of pediatric enrollees who were detected with diabetes in an ED setting actually had a PCP visit in the past year, but they were still not detected till they went to the ED. For type 1 diabetes, that's understandable. With type 2 diabetes, that's truly a missed opportunity. So, one of the things is uh, we would really recommend that pediatric caregivers are more diligent about screening if they believe the patient is at risk, to talking much more to the patient and the parents of the patient to give guidance if they are at risk, because health literacy among parents may not be as strong among the publicly insured population as it is among the privately insured populations. So we believe pediatric primary caregivers need to engage more. But I will tell you, we probably have about 4 or 5 different projects ongoing right now to just understand the different dimensions of delayed diagnosis or lack of appropriate screening and what's driving that.
Yeah, and I think also continuous enrollment is very important here. We see a very high, uh, very large increase in diabetes prevalence in 2021, and we suspect it's because the continuous coverage requirement by CMS during the COVID-19 period. I think this continuous enrollment may primarily benefit those who do not have like stable health coverage. They go on and off on Medicaid, so they do not have stable access to healthcare. And we believe it is possible that diabetes prevalence is higher among this population, or they do not have the chance to get diagnosed when they do not have health insurance.
Attempts to improve lifestyle through diet, nutrition, physical activity is has been going on for decades. There have been so many studies, so many attempts. Um, I think those have to be continued, but I think realistically, we may have to very seriously look at wider access to GLP-1 drugs, for example. I know it's not a very popular stance and the drugs are expensive, but we also have to be cognizant about the fact that we've tried nutrition and physical activity interventions for decades now. Um, so the drugs might become one more tool in the toolbox, but I think we really need to emphasize early screening and possibly an education to parents and caregivers to ask for that early screening if the providers are not preemptively sort of providing that. We are right now studying a very interesting policy that happened within Alabama Medicaid, where Alabama Medicaid simply required that the providers assess BMI and document that in claims. And one of the things we noticed, association again, we haven't tested whether this was causal, is when they started doing that, when they simply started documenting BMI because the program required them, diabetes screening went up. So it's possible that just something in that process of writing it down also sort of encouraged providers to think, oh, maybe this is somebody who we should also screen because I just wrote down that this child is obese. So those are potentially low-hanging fruit policy changes that Medicaid programs can consider. And then again, I'm going to emphasize if they can widen access to GLP-1 drugs. I know we are very early there. I know there's potential side effects to be concerned, but this is also the pediatric diabetes is also a very serious problem. So it's worth considering that.